the World Massage Conference.
Hello and welcome to the World Massage Conference. I'm your host, Scott Dartnell, along with my special co-host, Drew Freeman, for this presentation on functional range release, introducing a new system of manual therapy forged by research, presented by Dr. Andreo Spina. If you are attending the live presentation, be sure to log into the chat room. Use your Facebook or Twitter ID to log in, and we'll be able to see your picture, and you'll be able to connect with others you meet here in the chat room. And if you'd like to ask questions of a presenter, Dr. Andreo Spina, simply click on the blue Ask Question button and submit your question. Our co-host, Drew Freeman, will try and get to as many questions as possible during our live presentation. Thanks to our global sponsor, Massage Envy. Massage Envy is committed to supporting your profession. Massage Envy is donated to organizations that promote the healing benefits of massage and careers in massage therapy. Visit MassageEnvyCareers.com and click on the Giving Back tab for more information, or visit Massage Envy on Facebook. Thank you to our daily sponsors, Associated Bodywork and Massage Professionals, Massage and Bodywork Magazine, Massage Today, Massage Warehouse, the Upper Ledger Institute, BioFreeze, and Bone Vital. Our presentation today is on functional range release, introducing a new system of manual therapy forged by research. New research continues to accumulate in the world of manual therapy. Has our approach to soft tissue therapy kept up with the times? Join international speaker Dr. Andreo Spina as he introduces you to functional range release, soft tissue management system, a system forged out of the current knowledge regarding soft tissue mechanics and cellular histology. Tune into this presentation to find out if the current research discussed causes you to question your personal approach to the treatment of soft tissue lesions. Dr. Andreo Spina holds a Bachelor of Kinesiology from McMaster University. He graduated summa cum laude and clinic honors from the Canadian Memorial Chiropractic College as a Doctor of Chiropractic, and subsequently completed a 2-year postgraduate fellowship in sports sciences. Dr. Spina is the creator of Functional Anatomy Seminars, which offers courses in advanced soft tissue palpation and assessment system called Functional Anatomic Palpation Systems, as well as a new fascial release and rehabilitation system called Functional Range Release. These seminars are offered worldwide to students of all manual therapy disciplines. Good morning, Dr. Andreo Spina, and thank you for joining us on the World Massage Conference.
Good morning to everyone.
We're very happy to have you here, and we're excited to get started with your presentation.
All right, we get to go right now if you'd like.
We are good to go.
Okay, good morning to everyone out there in internet world. As the title of the presentation suggests, I'm going to be introducing you to my soft tissue treatment system, which is entitled Functional Range Release. And just so we kind of get a basis for what functional range release is, in my opinion, it's not only a technique, but it's actually a thought process. And what I want to do today is kind of walk you guys through a very brief introduction to my thought process as I developed the system out of the current research that has been developed surrounding soft tissue mechanics, histology, etc. So without further ado, let's go to the next slide, Scott. So here's kind of the outline as to what we want to discuss today. First, I want to redefine the target tissue. I want to start to question or have you guys question your own mind what it is that we're actually treating. And what it is that we're actually treating will be very important in terms of how we're actually going to go about treating it, which is one of the big differences in the functional range release system, is that we redefined our target tissue and then looked at the research and decided what is the best way to affect said target. This, of course, will all make sense in the next few slides. The next thing we're going to talk about is assessing the target tissue. What is the way that we actually find soft tissue lesions that are amendable to soft tissue treatment and care? Then we're going to discuss the actual functional range release treatment. And then I have on the same line rehabilitation and conditioning. And I have that on the same line because the FR system is not only a manual therapy treatment, but it also incorporates rehabilitation as well as soft tissue conditioning during the actual treatment encounter. And then last but not least, we'll go over what we call the functional range release patient management system, which is really a thought process as to how FR certified practitioners take patients all the way from their intake and clinical history right down through their treatment and rehabilitative process. Next slide, please. So the first thing we're going to do is discuss the target tissue itself. Now, soft tissue techniques primarily in the past have focused on the treatment of muscle. It's kind of the way that we were taught, you know, the person's hamstrings are tight or their trapezius is tight, therefore we're going to apply soft tissue application or technique to these quote tight muscles. Now, the problem with this mentality is when you actually think about what a muscle is composed of, it's simply composed of contractile fibers, actin, myosin, titin, etc. And then we have the innervating motor neuron. Now, the goal of soft tissue treatment is not necessarily to break apart actin and myosin bonds. That's relatively easy. For example, if you bend your forearm or your elbow, you make actin and myosin bonds, and if you straighten out your elbow, you release them. So it's not the goal to break up those fibers or those actin and myosin bonds, nor is it the goal to rip out the innervating motor neuron. So really, when we were developing FR release, we had to stop and think, what is it we're actually trying to do? So if we look at the composition of a muscle being only contractile fibers and innervating motor neurons, there is one component that is commonly left out in anatomy textbooks, and that would be the fascia or connective tissue. Next slide. The fascia and connective tissue is really the tissue that forms the scaffolding on which or in which the muscle fibers sit. Next slide. So going back to the goal of soft tissue treatment, if it's not to break up actin and myosin bonds, and if it's not to break up or to rip out the innervating motor neuron, what is the goal of our soft tissue therapy? Next slide. The goal as we saw it is the removal of scar tissue or fibrosis. So when people apply their hands on a patient and they're assessing for, let's say, tissue restriction or tissue tension, they're actually feeling for aberrant fibrosis or aberrant scar tissue. Now, where does this scar tissue actually form? Next slide. The scar tissue forms within the fascia. And I don't want to just limit ourselves to fascia. I actually want to think in terms not only of fascia, but of connective tissue in general, fascia being one of the most abundant connective tissues in the body. But this also includes tendons, ligaments, cartilage, even the substance making up blood vessels, the substance making up 80% of nerves is connective tissue. So our target is actually the removal of aberrant connective tissue, which is scar tissue. We all remember that regular tissue is tissue laid down along nice parallel lines. So you have collagen deposition by fibroblasts that are along nice parallel lines and in nice parallel sheets. If the deposition of this tissue is laid down in a haphazard fashion, then we call that scar tissue. And that scar tissue that develops within fascia, within all of the other connective tissues, is actually our target. Now, if we go to the next slide, I'm just going to introduce to you some of the ways that we kind of break up the fascial system into discrete sections. There is really, if we look at fascia and connective tissue, we can break it up into three sections. The first one being fascia superficialis, the second one being fascia profunda, and the third one being the deep fascia. The fascia superficialis is the layer, as you can see on the picture, that really adheres the skin to the underlying muscular tissue. So it's a layer of connective tissue with deposits of fat, so it's otherwise known as the subcutaneous layer, and that layer kind of adheres the skin to the underlying muscle. There is movement of this layer. For example, if you just take your hand and touch the skin on the back of your forearm, if you were to move the skin around, you can feel that there is a little bit of play. There is a little bit of ability to kind of wiggle or move the skin over the underlying muscles. So this layer is referred to as the fascia superficialis. Going deeper to the fascia superficialis, we have what's called the fascia profunda. The fascia profunda is the fascia or connective tissue which encapsulates entire muscles, which we know as epimysium, or encapsulates muscle bundles, which we know as perimysium, or encapsulates individual muscle cells, which we know as endomysium. So that would be the fascia profunda layer. So we have a fascia superficialis layer, and then we have a fascia profunda layer, which actually surrounds all of the muscles. And then we have what's called the deepest layer of fascia. The deepest layer of fascia is the fascia that surrounds the actual nervous system tissue. So, for example, the dura mater around the spinal cord would be a deep fascia, or the deepest layer of fascia. Now, this is conceptually how we break up the layers, but in reality, in the human body, all of these layers are completely intermingled and intertwined. So, for example, if you were to move the skin on top of your forearm, you would have a little bit of play between fascia superficialis and profunda, but eventually you're going to hit into a barrier where you can no longer move the skin. That barrier is present because of the fact that there is adherence between all of the layers. So it's not like we can just take all these layers and slide them past one another freely. There is connection between all the layers. Now, if we go to the next slide, we see our little caricature here who is asking who cares, and that's probably what you should be thinking at this point in the presentation. What is the difference between what target tissue we're using? If I'm claiming now that the target tissue is not muscle, but it's the connective tissue and the fascia encapsulating and surrounding the muscle, then why don't we just assume that all of the treatments that we've been applying up until this point will work on fascia? We can just change our mind and say we're no longer treating the hamstring, we're treating the fascia and connective tissue associated with the hamstring. Well, the problem is that it's not just a matter of nomenclature. The way that the connective tissue responds and the way that fascia responds is a lot different than the way that muscular tissue responds. So if we go into the next slide, we see that the way that connective tissue will respond to the application of any manual technique is not the same as muscle. Muscle is a neurologically innervated tissue. It responds very, very quickly. It responds to pretty much any alteration in nervous system activity, whereas the connective tissue has a different way of responding. For example, you need to put more load into connective tissue. You need to hold the load application for longer periods of time, et cetera, et cetera. And it's these differences in how connective tissue and fascia responds versus how muscle responds which really prompted the creation of the functional range release system. Next slide. Two of the major differences that separate the FR system from a lot of the other soft tissue systems out there is time and intent. Next slide. Now, regarding time, as we previously noted, the fascia does not respond in the same way as does contractile muscular tissue. The studies show that application of the load, or application of our hand putting load into the tissue during soft tissue treatments, the studies show that it has to be held for a much longer period of time, upwards of 2 minutes. And that 2-minute mark is really so we can induce the process of piezoelectricity. Now, what is piezoelectricity? Piezoelectricity is the idea that with an external force application, i.e. our hands doing soft tissue treatment, we can alter the way that the fibroblasts, which are the cells that actually create fascia, we can alter the way that the fibroblasts deposit tissue. So as we're breaking up scar tissue, which takes a long time, upwards of 2 minutes, we can actually influence the way new tissue is laid back down. But we can only do that if we allow enough time for the fibroblasts to register that a load is actually being applied. Now, if you go back to some regular myofascial release techniques, let's say you shorten a muscle, put a load into the muscle, or pin it down and then lengthen it, and then shorten it up again within about 10 seconds, which is usually how it's done. That doesn't allow ample time for the fibroblasts to actually feel the load that is being applied, and therefore they will not alter their cellular processes. With functional range release, we take this into account. As we're treating, we're allowing enough time for this piezoelectric effect to take place. An easy way to think about this is your fascia is much like pizza dough. If you were to take pizza dough and kind of pull it apart on either end and then let go right away, the pizza dough would contract back down to its original size. However, if you were to take a hold of the pizza dough on either end and pull it apart and then wait and allow time for that force to take effect, you would actually cause a plastic deformation or a permanent deformation in the pizza dough. This is really how fascia works. It takes time in order to actually alter or change the physical composition or physical structure of the fascia. And this is one of the differentiating ways that this is one of the ways that the FR application or treatment using FR technique is different than many of the other soft tissue techniques that are currently being utilized. If we go to the next slide, the next real change in how we do soft tissue treatment in the FR technique is with regards to intent. By intent, what I mean is what we're actually trying to accomplish on a gross tissue level and on a cellular level when we're actually applying soft tissue treatment. Now, as we described before, we described the three layers of fascia. We have the fascia superficialis, we have the fascia profunda, we have the deepest fascia. Now, in order for normal mechanics to occur, in order for normal movement to occur, there has to be a certain degree of interlayer sliding between the fascia superficialis on top of the profunda, between the various components of the profunda. For example, one muscle needs to be able to slide past another muscle. One muscle bundle needs to be able to slide past another muscle bundle. Each muscle cell has to have certain amounts of independent motion. If we don't have these independent motion, let's say that there's scar tissue in between two muscle bundles or in between the fascia superficialis and the fascia profunda, then we get restrictions in soft tissue movements. So if we go to the next slide, we see that injury, be it cumulative injury, be it acute injury, will lead to the deposition of fibrosis. The deposition of fibrosis, because it's occurring in the fascia, it will cause adherence between all of the different fascial layers. Adherence between the fascial layers will lead to a loss of this relative tissue motion or sliding, and the loss of that relative tissue motion and the friction associated with that loss of sliding is really what causes our pain, our altered biomechanics, our decreased force production capabilities, etc., etc. So in other words, when fascia is deposited in the connective tissue, what the ultimate effect is it causes a loss in the ability for soft tissue layers to slide past one another. It is that loss of ability of soft tissue layers to slide past one another that alters the mechanics. It is the altered mechanics that leads to pain. And this is really the intent of FR treatment. It is to improve the amount of relative tissue motion between different soft tissue layers by breaking up the fibrosis. And going back to what we said before, the soft tissue technique allows enough time to actually break apart or to change the composition of our target, if that makes sense. I hope it does. Now, if we go to the next slide, because the intent is really to move one tissue past another tissue, what that means is in order to actually cause a good amount of relative tissue motion, or in order to break up this scar tissue, it means that our soft tissue treatment application has to involve motion. Next slide.
Dr. Spina, I just want to confirm what slide we're on.
We are on the slide that has the two pictures, the one of the fascia superficialis on the bottom left and the one of the honeycomb appearance of the connective tissue on the right. So it would be slide number 16.
Thank you.
Okay. So, as I was saying before, if the intent is to slide tissue layers past one another, that means that we actually have to create motion in between these two layers in order to create, or in between whatever layers are adhered to one another. In order to actually create motion between the two layers, the soft tissue technique has to be applied with actual motion from the patient. If we don't actually move the patient, then we will be unable to actually break apart the scar tissue between the layers. The next series of slides is a way for me to kind of give you a visualization as to what I mean. So if we go to the next slide, slide 17, I have here a picture pretty much of two pencils and a cotton ball. Now, if you imagine with me that one pencil represents, let's say, a muscle or a muscle bundle or a muscle fiber, and the other pencil represents another muscle, let's say a parallel muscle or another bundle of fibers or another fiber itself. In between we have fibrosis. Now, as I said before, in between every fascial layer there is some degree of connectivity. However, when the connection or when the fibrosis becomes mature, we call this scar tissue because it will restrict relative tissue motion. Now, if we go to the next slide, imagine that we just take, let's say, some massage oil and we apply it to the skin of the patient, and then we apply compression and we start to slide over the surface of the skin. As is demonstrated by this picture, you can see that we're not actually changing the relative tissue motion between one muscle or the other, or one bundle or another, or in the case of our picture, one pencil or another. Because we're sliding over the surface of the skin, all we're doing is pretty much compressing the tissue, but we're not changing relative tissue motion. Now, if we go to the next slide, this slide represents something different. This time, instead of only utilizing compression, we're also applying tension or a force parallel to the muscle bundle, and then we are actually inducing patient movement. Now, by inducing patient movement, you can see that we can change the relative position between one pencil and another pencil, or the relative motion between one muscle and another muscle. So because we are inducing relative tissue motion, you see that the fibrosis begins to become stretched. And if we go to the next slide, if we hold that compression plus tension plus movement for long enough, we will actually break apart the soft tissue fibrosis, or we will break apart the scar tissue, which is adhering one muscle to another, or is adhering one bundle to another, or one cell to another. So really, the point of the last few slides is to demonstrate that if we don't actually use patient motion, we cannot change the relative position between the tissues that we're trying to treat, and therefore we cannot break apart scar tissue simply by sliding over the surface of the skin. Next slide. So I've kind of outlined a few of the problems that I saw with this current soft tissue treatment and kind of the background information that I utilized in order to develop the FR technique. So there's quite a few changes already, but we actually have another problem that we have to deal with. So if we go to the next slide, up to now, or up to this slide, we've talked about the fact that fascial release following injury is really necessary to restore proper mechanics. We have to induce that relative tissue motion in order to normalize soft tissue movement. Next slide. However, the next problem we run into is that after injury, we get muscular contraction. So when we injure ourselves, the nervous system, because of protective reflexive mechanisms, will actually cause contraction of the muscle. And we refer to this contraction of the muscle as the neuromuscular barrier. Now, if our target is the connective tissue, the passive connective tissue or fibrosis that occurs within the fascia, if a muscle is tight, it will prevent us from moving the person's body or moving an articulation into the outer ranges of motion. And because that contraction is preventing us achieving outer ranges of movement, we will actually be restricted in the amount of fibrosis that we can actually access and treat. So, in other words, when we have an injury and a muscular contraction, it will prematurely guard our end range of motion, which will really restrict us from treating the target, which is the fascia. So we have to have some way of overriding the nervous system in order to allow the muscles to relax so that we can really assess and treat our target, which is the connective tissue and fascia. We'll talk about that a little bit later, but now, if we go to the next slide, I really want to go over some of the assessment principles that we utilize in order to find our soft tissue lesions. Next slide. The first thing that we utilize when we're assessing is pretty much palpation. Now, if you are interested in taking the functional range release seminars, you'll note that there is a prerequisite course, and the prerequisite course is referred to as Functional Anatomic Palpation Systems. The Functional Anatomic Palpation System seminars, or FAP, really take individuals through a system of palpation in order to improve our ability to not only localize very specific anatomical structure, but then also to teach people how to use our palpation skills or enhance our palpation skills so that we can actually feel losses in relative tissue motion. So in terms of assessment for the functional range release system, the FAP palpation system is really our first and most important method of assessing soft tissue structure. It allows us to localize the pathology to a very specific anatomical structure, and then not only to localize the pathology, but to then assess why the pathology is actually occurring, or what scar tissue is preventing whatever structures from sliding past one another, or where we have losses in relative tissue motion. Next slide. The next assessment principle that we utilize in FR is really an assessment principle that is not taken into account with a lot of soft tissue treatment methods, and that is what we call the layering technique. The layering technique allows us to account for the fact that all of our patients are actually three-dimensional beings, not two-dimensional pieces of paper or two-dimensional pictures of anatomy. Our patients actually have depth. They actually have layers of tissue that kind of form more superficial layers, and then we go deeper and deeper and deeper all the way until we hit really the bone underlying all of our soft tissue. So I'm going to give you an example of the layering technique. As you can see in the pictures, I'm assessing here the triceps surae group. Now, we all know that the triceps surae group is really made up of three distinct soft tissue layers. We have the gastrocnemius. Underneath the gastrocnemius, we have the soleus. And then underneath the soleus, we have the deepest layer, which would be the tibialis posterior, flexor digitorum, and flexor hallucis longus. Now, the layering technique allows us to differentiate these layers in order that we can assess and really specify which layer the problem is actually occurring. For example, in the first picture on the top left, we have the person's leg completely straight, and you notice that I'm dorsiflexing the ankle. Now, because we keep the knee straight and I'm dorsiflexing the ankle, we're now assessing the most superficial layer, the gastrocnemius, which is a two-joint muscle. Now, in order for me to think through the gastroc and begin to assess the soleal layer, what we want to do is we want to bend the knee, thereby relaxing the overlying gastroc, keeping the ankle dorsiflexed. This puts us at the layer of the soleus. And then if we want to get deeper than the soleus, as you can see in the bottom right picture, we now plantar flex the ankle. That will put us at the deepest layer where we have the tibialis posterior, for example. So using the layering technique, we are able to layer ourselves from more superficial structures into deeper structures so that we can be more specific as to which exact layer our soft tissue lesion exists. This is important not only for assessment but also for treatment, because there has to be a way to treat the tibialis posterior that differs from the way that we treat the gastrocnemius. There's really no way, if you look at the top left picture, there's no way to access the tibialis posterior. It's much too deep, and the overlying gastroc and soleus would prevent us from sinking deep enough. So the layering technique in the FR system allows us to account for these changes in tissue depth. Next slide. Now, the next assessment principle that we discuss is something called tissue tension technique. As we alluded to before, what I'm actually trying to find when I'm assessing soft tissue treatment is I'm trying to find losses in relative tissue motion. In order to assess for these losses, we are going to have to actually take the person's articulation, as you can see in the picture, and move them through various ranges of motion. By moving them through various ranges of motion, we palpate for what we refer to as aberrant tension. Aberrant tension would be representing scar tissue or fibrosis located in between soft tissue layers, which is preventing motion from occurring. So in other words, in the picture, I have my hand on the anterior pectoralis region. What I would be doing is I would be passively taking the person's arm through various ranges of motion and trying to feel for the buildup of abnormal tension under my hand. Now, you may be wondering, what is abnormal tension? Well, here's the best way to describe it. If you were to feel a muscle, and you were to feel the muscle at the very end range of motion, what you would feel is a very rapid onset of tension as the end range of motion occurs. What I'm feeling for with the tissue tension technique is I'm feeling for the same sensation of tension building up into my palpating hand, but I'm feeling for that tension to build up before the end range of motion. So in other words, abnormal fibrosis or abnormal tension is tension felt not at the end range of motion, but within the normal range of motion of a particular articulation. If I feel abnormal tension within the normal range of motion, then that by definition is a force which is hindering the entire range of motion from occurring, and therefore it's abnormal. That is really the target of the functional range release system. It is to treat that abnormal tension which is preventing a nice fluid range of motion from occurring. If we go to the next slide. The tissue tension technique can be utilized not only to feel for restriction or loss of relative tissue motion between muscles, but it can also be used to feel for loss of relative tissue motion between the fascia superficialis, or the subcutaneous layer, as it sits on top of the muscular layer. We call this interlayer sliding assessment. What that means is we're assessing the ability for the skin to slide over underlying muscles. Now, for the more experienced therapists out there, I'm sure you will agree that if you have a condition which has become chronic, you'll notice that the amount of skin slide that can occur over the area of the injury will decrease. Let's say, for example, we have a chronic sacroiliac joint problem. I'm sure a lot of you have felt that the skin over the PSIS is restricted. It doesn't have as much motion or as much ability to slide over the underlying PSIS or over the underlying soft tissue layers. This would be what I'm referring to when I say we're assessing interlayer sliding, the ability for the fascia superficialis to slide over the profunda layer. So one of the assessment techniques we use in FR is to use the tissue tension technique to try to look for these fascial adhesions between the skin and the underlying tissues. Next slide. We also will have to assess for fascial restriction within the muscle, and that would be what we refer to as intralayer sliding. So this is when we're actually taking the person's articulation, moving it through various ranges of motion in order to feel for restriction either between muscles or restriction between bundles of muscles or between a tendon and another muscle, etc. So the assessment principle, the tissue tension technique in FR, we apply it to assessing the motion between the skin and the underlying muscle, as well as between muscular tissues. Next slide. So now that we've talked about what we're assessing for, we're assessing to look for the exact lesion. We're assessing for the exact tissue depth where the lesion, is occurring. We're assessing to see in between what structures is the fibrosis present, where is the loss of relative tissue motion located. Then we're going to go ahead and we're going to treat. Next slide. So if we were to, let's say, find restriction between the skin and the underlying muscular tissue, we have a method in the functional range release system in order to deal with those types of restrictions, and that's called interlayer treatment. Interlayer treatment looks to break apart fibrosis occurring between the fascia superficialis and the underlying profunda layer. The treatment technique that you're going to see in the video a little bit later on really utilizes some skin rolling type techniques or some wedging of the skin over the underlying profascial layers, and then profunda layers, and then we're actually holding this tissue force for very long periods of time in order to try to break up the fibrosis. Next slide. after we've assessed and treated the overlying skin, then we're actually going to go into the muscle and we're going to apply forces and utilize motion in order to try to break apart the scar tissue that occurs in between muscles or in between muscle bundles. This is what we refer to as intralayer treatment. With intralayer treatment, what we're trying to do is we're trying to locate the area of the tension, and then we're going to apply a force, and we're going to kind of play in the last 10 degrees of that palpated tension in order to hold our soft tissue force long enough to allow breaking of that fascial tissue or breaking of that fibrosis. Next slide. So a lot of the description that I just went through with regard to how we assess and how we treat will probably make more sense to you once you watch the video. But what I want to talk about now is going back to that other problem that we had, and that being the neuromuscular barrier. Next slide. If our intent is to actually access the connective tissue and scar tissue and fibrosis that occurs within the fascia, with injury, if the muscle becomes contracted, we have to have some way of getting through the muscular contraction in order that we have good access to the fascia and connective tissue. So in other words, the potential for our soft tissue technique to release fibrosis really depends on the state of muscular contraction. And that state of muscular contraction is really set by the stretch reflex. When we have injury, what happens is the stretch reflex threshold decreases. And if the stretch reflex threshold decreases, the muscle spindles become more sensitive. That means as we try to move our patient through a particular range of motion, the range of motion will be preemptively blocked because the nervous system is trying to protect the injured area. In other words, the nervous system will increase neural drive to the muscle, and it will prematurely restrict the end range. And that's really going to block our ability to feel for fascial fibrosis and to feel for fascial tension. Next slide. Now, whereas traditional forms of soft tissue treatment have really been applied only to the range of motion that is allowed by the nervous system, for functional range release, we have a way to overcome this neurological barrier and to temporarily alter the nervous system activity, which will allow us to expand the range of motion and thereby have better access to deal with the fibrosis or better access to treat the scar tissue which is accumulating. Next slide. What we use in order to trick the nervous system into allowing these ranges of motion is something called PAILS, or progressive angular isometric loading. So the main goal of progressive angular isometric loading is to, like I said, trick the nervous system into allowing us access to more ranges of motion. And not only do we use this technique to allow us access to the new ranges of motion, but we're also going to utilize the opportunity to strengthen the newly acquired range of motion. So in other words, the progressive angular isometric loading allows us to trick the nervous system into getting more range. So if we're treating, let's say, the hamstrings, and the hamstrings are only able to extend to 80 degrees, progressive angular isometric loading will allow us to trick the nervous system into giving us, let's say, 10 or 15 more degrees. That 10 or 15 more degrees allows us access to our target or our connective tissue which we're trying to assess and treat. When we get the nervous system to give us that next 10 to 15 degrees, we're also going to start to strengthen that newly acquired range of motion. So not only are we going to temporarily expand that range of motion, we're also going to teach the nervous system how to control that range of motion. Next slide. And by teaching the nervous system how to control that range of motion, we will teach the nervous system how to incorporate that new range of motion into our functional ranges of motion or into our functional movement. Next slide. So in this slide, we're going over what we call PAILS Level 1, and there's 3 levels of PAILS. PAILS Level 1 would be very similar to PNF type stretching or PIR type stretching. So let's say, for example, we're treating the hamstrings as is indicated in the picture. If we are treating the hamstrings and we're releasing soft tissue fibrosis. We're palpating for abnormal tension, and we get to an end range of motion which is restricted because the nervous system is blocking it. By simply asking the patient to push against us temporarily and then to relax, what happens is the nervous system will actually calm down and it will allow us another 10-15 degrees of motion. So in this situation, the treating practitioner will then move the articulation into the next 10-15 degrees of motion now allowed by the nervous system. Now the practitioner will assess the new range of motion that has been granted to us by the nervous system. And as we're assessing this range of motion, we're looking for tension, which we're going to treat, and then we're going to continue. So we're going to continuously try to expand the range of motion as we treat. Next slide. Once the patient starts to get better and once the pain levels reduce, not only are we going to utilize isometric contractions just to temporarily expand the range, but we're going to get the person to now start to contract harder. And by contracting harder, we're going to start to teach the system how to actually utilize the new range of motion by strengthening the body's ability to contract within that new range. That really is what we call PALS level 2. Next slide. Then we have PALS level 3. PALS level 3 is what we refer to as functional range conditioning. Functional range conditioning is really expanding upon these principles into more conditioning our outer ranges of motion. So this is a system which will really teach the person to improve their levels of flexibility and mobility. Next slide. So really the reason that we're using the progressive angular isometric loading in association with our functional range release soft tissue treatment is as follows. Number one, it's to temporarily increase the range of motion, thereby allowing the treating practitioner to more thoroughly access and subsequently treat the soft tissue areas that have tension. We're also using it in order to teach the nervous system how to utilize the newly acquired ranges of motion, or teach the system how to recruit the motor units that control these outer ranges of motion in order that we teach the nervous system how to incorporate those ranges of motion into our functional movement patterns. We're also going to utilize this isometric training in order to increase neural drive to the tissue, so we're preventing post-injury inhibition. And we're also using this isometric loading in order to improve patient flexibility and improve patient mobility, or their ability to actually move. So the functional range release system, in essence, is looking for areas of soft tissue fibrosis between fascial layers. It's releasing the soft tissue fibrosis between fascial layers. It's expanding ranges of motion across articulations, and it's subsequently teaching the nervous system by way of isometric training how to control the newly acquired ranges. Next slide. So as I had alluded to before, this system is not only one of treatment, but it's also of assessment, treatment, rehabilitation, and conditioning, all occurring at the same time. So we use our FAP palpation skills to find areas of tension. We use functional range release to release areas of aberrant fibrosis, which is restricting relative tissue motion. We utilize progressive angular isometric loading in order to start the rehabilitative process, in order to start to strengthen the tissue that we're treating. And we also use progressive angular isometric loading in order to begin to condition the patient to be able to control their outer ranges of motion. Next slide, Scott. We should be on number 43 at this point. So the last slide here is really our patient management flow chart, and this hopefully will give you an indication as to what we actually do as functional range release practitioners when we get a patient in. So when the patient presents, obviously I'm going to go through a history, just like anybody else is. I'm going to go through a history trying to find out what is the actual process occurring, where the problem is. If you look on the left side of this chart, we see that it says increasing specificity. So moving from our actual patient history, we're then going to utilize the functional anatomic palpation systems to really specify the exact area of soft tissue pathology. What is the exact structure which has the soft tissue lesion? So as we go from clinical history into assessment, we really want to get more and more specific and nail down the exact area of the lesion. Once we have the area of the lesion, once we've located, let's say, which muscle or which tendon or which ligament is the actual problem, we then want to utilize the tissue tension technique to try to understand where the areas of fibrosis are occurring, which either leads to the actual pathology or what is the result of the pathology. So in other words, if there's an acute injury, there will be fascial fibrosis, there will be scar tissue that develops. That will cause aberrant motion between tissues. So the tissue tension technique, we're going to be looking for where are the lines of tension which are affecting the tissue, which is the painful structure. Once we understand which is the actual tissue that has the lesion, once we understand the areas of fibrosis and how they're affecting the mechanics by changing the relative tissue motion, then we're going to start to apply functional range release protocols. We're also going to start to apply PALS level 1. So we're going to take that lesion and we're going to start to break apart the aberrant fibrosis. We're going to use progressive angular isometric loading to try to kind of free up the range of motion. Now, at this point, after we've treated the patient, let's say 1 or 2 times, if we do not have improvement, we're going to go right back up to our clinical history. I believe that if we don't find improvement over the first, let's say, 2 to 3 visits, that means there's something wrong with our diagnosis. Either we did not specify specifically enough what is the actual soft tissue lesion, or there's something else going on. So that will kick us back up to the clinical history. However, let's say that the person is improving. Let's say that we found the lesion, we've treated them using functional range release, we've started the rehab program with the progressive angular isometric loading, and the person comes in 2 to 3 visits later and they're getting better. Now, if you look on the left-hand side, you see that the specificity will start to decrease. So now, instead of only focusing on the lesion, now what we're going to do is we're going to utilize the tissue tension technique on a more broad area of soft tissue. We're going to be looking at other articulations in the area which may be aberrant, other articulations which may not be moving, other areas of soft tissue along the kinetic chain which may be contributing to our soft tissue problem. We're then going to apply functional range release techniques to the other tissues that might be contributing aberrant tension, that might be, let's say, contributing to the original pathology. And then we're going to start to move to PALS level 2. We're going to start to actually strengthen the ranges of motion. And then as the patient continues to improve, we will go into PALS level 3, or the functional range conditioning, where we'll start to assign the patient exercises so that they can improve their mobility, improve their flexibility. At that point, once the patient is pain-free, we can either discharge them or we can have them come back in for what we call maintenance or performance care. Maintenance or performance care pretty much entails the patient comes in, we assess or we palpate for any areas of aberrant motion or lack of relative tissue sliding, and then we apply the FR release protocol to these areas in order to keep the person functioning properly. So if we go to the next slide, it's pretty much the end of the presentation or end of the PowerPoint. I just wanted to point out here that if you want any more information, it's very difficult to get this much content into a 40-minute presentation. If you want more information, you can get that information at our website at functionalanatomyseminars.com, or you can go onto the blog, which is functionalanatomyblog.com. If you really type in any of the concepts that we've discussed, progressive angular isometric loading, fascia, tissue tension technique, if you actually do a search on the blog, there will be several posts that will hopefully better describe these concepts or give you more detailed descriptions of those concepts. You can also join us on Facebook, facebook.com/Functional Anatomy Seminar, or you can follow me on Twitter at Dr. Andreo Spina. And those are ways that you can kind of learn more about the technique. And our last slide, I just want to say thank you for joining me for the presentation. I'm very interested in hearing any questions that you might have, and hopefully the video that is going to follow will be able to clear up any confusing areas of the talk that I just gave.
Well, thank you very much, Dr. Spina. That was a fascinating presentation. We do have some questions. I'm going to go to my co-host, Drew Freeman. Drew, are you there?
I am here. How are you guys doing, all right?
We're doing well. We're doing very well.
I'm actually out of breath because I had to put a lot of content into a very short amount of time.
That was quite a bit. You had quite a few slides going there. That was excellent stuff, though, Dr. Spina. I really appreciate you taking the time to pull that all together for us. It's always informative and wonderful to hear you speak about this. First question comes from Drew in Boston. He wants to know when you're coming to Boston to present.
I will be coming to Boston to present as soon as Drew can set up some nice areas that we can go visit, the day before and the day after the seminar. How about that?
That sounds good. I heard he's a wonderful guy and he's a great host in his town, so I'm sure he'll set that up for you. So I had to throw that one in there. Actually, here's a good one for you just to start off, because this work, I've been hearing you talk about this for quite a while now, and obviously I've been following your blog and your YouTube posts, and I'm going to post those links on the chat room as well. But can you share some of your own personal client success stories that you've had with utilizing this technique?
I suppose everyone has success stories, so I don't know that I want to kind of give a particular success story, only because of this reason. There's a lot of people, you go to seminars and they have these kind of,
Sure.
This is what I did with this patient and he got amazingly better. Well, you know what?
Mm-hmm.
I don't know that I particularly like doing that. I obviously make people better, just like you do, Drew, when you treat your patients.
Yeah.
So I think a better way to answer that question is as follows. I'm a student of manual therapy. I am really interested in getting as good as humanly possible as I can at feeling soft tissue lesions and treating soft tissue lesions. I look at every patient as a science experiment in a way that I am really trying to understand what is going on through my fingers. I want to be able to see through my fingers. I want to be able to know exactly what's happening through my ability to touch and feel, and then I want to be able to treat that tissue. The way that I came up with functional range release is it wasn't something, that I woke up one day and I said, oh my God, I have to change everything so that I can start a seminar series. It was really a process of using what was out there. I've taken various soft tissue techniques. I've done almost every seminar you can think of. And through experimenting on patients, this is the best thing that I've come up with. This is the best thing that I can really say has good research background. So by combining what I read in the research and what my experiences were, that's why I use functional range release. It's not because I wanted my own system. I just wanted the system that had the best possible results. And it wasn't until I started bringing all of these concepts together that I started to notice an incredible improvement in my patient results. So, of course, every soft tissue treatment I use, I got results. But when I started to get all of the concepts working as a cohesive unit, that's when I started to go, oh, my goodness, I am fixing things a lot faster than I was before. So it's really one success story. It's a journey of really focusing on getting better. And functional range release is really the culmination of that journey. It's what came out of the research and the experience.
Yeah, I wholeheartedly agree. I think, patients ask me all the time, how long until I get better? And, just because I've had success before with patients doesn't mean that I'm going to have the exact same success with you. You've got to take it one patient at a time. You're only as good as your last patient's success story, really.
Absolutely. That's why you have to incorporate what the research tells us. That's why I wanted to create out of the research. I wanted to see what is it that we actually know and how can we best apply what we actually know. And that's why, of course I'm going to say functional range release technique gives amazing results, but it's not just because it's a new technique that's kind of the sexy new thing. it's because it was developed out of what we know. If that
Mm-hmm.
makes sense.
Yeah, it does make sense, and I think it's important to have techniques that are out there that are based and built around research, not just opinion and thoughts and ideas.
Mm-hmm.
So here's another question from Steve in Toronto, actually. It says, do you need to have the client move, or is all the movement passive? Where with the client's lens? Yeah.
I only utilize passive movements, and I'll tell you why. Going back to the neuromuscular barrier, let's say that someone was injured. Let's say that, for example, their hamstring got injured. If their muscle is now going to, if the nervous system is going to increase the neural drive to the muscle, or it's going to sensitize the stretch reflex, if I get the patient to go through the range of motion, the motion will be incredibly restricted. Everyone knows that if you take an articulation and you move it through a passive range of motion, it's a much greater motion than an active range of motion. Now, why is that? The active range of motion is really only looking at what the nervous system is allowing, whereas passive range of motion is actually assessing the connective tissue structures. So when I'm treating, if my goal is to break apart fibrosis, I don't want the muscle to be involved in my assessment and treatment process. I want to bypass the muscle, and therefore I want it to be a passive motion. So by passively moving the knee into extension, I can assess the actual connective tissue. If I got someone to actively do it, I wouldn't achieve a great range of motion, and therefore I would be restricted in the amount of connective tissue I can access and treat.
Mm-hmm. Right. That makes complete sense. It's one of the questions here is, in some of the pictures, the work looks to be very deep. Do most clients find this very painful?
The easiest way to answer that question is it's really not a concern of mine. It's not that I want the patient to be in pain. However, I will say that to get to a deeper structure, I do have to layer myself deeper. One of the ways that I minimize the pain is by using the layering technique. So, for example, if I want to assess and treat the tibialis posterior, if I have the leg straight, if I grab that person's calf and just plunge my thumb as hard as humanly possible until I get deep enough to treat the tibialis posterior, it would be incredibly painful. However, going back to my example about using layering, if I am able to layer myself down into the deepest layer, I don't have to use as much compression. So I can access these deep layers without having to compress and really hurt the patient. Now, are my treatments pleasant? No, I wouldn't call them pleasant, really, but they are less painful than they would be if you did not account for this layering concept.
Sure.
Now, getting back to that question, one more thing I want to add.
Sure.
How deep do I go? I go exactly as deep as I need to. If the lesion is in the obturator externus, well, then I have to go deeper than the pectineus in order to access it. If the lesion is between the skin of over the PSIS and the PSIS itself, then I don't have to go that deep at all. It all depends on the exact tissue layer that has the pathology.
Excellent. So one of this woman, Dawn in New York, wants to know, do you have any specific tips or tricks that you would recommend for honing in on your palpation skills?
Any tips and tricks? Yeah, I mean, the FAT system is in fact a system we use. Reference structures. We use a layering system. It's a very involved system. But if I were to say one thing that I would really concentrate on to improve my palpation skills, let's say this morning after this presentation is done, I would say it's to account for tissue depth. Like I was discussing, none of our patients are two-dimensional. None of our patients look the way they look on paper, let's say in an anatomy textbook. There is depth to our patients. There is overlying structures, underlying structures, etc. So in order to really hone palpation skills, you have to be able to layer your way through in order to differentiate more superficial tissues from deeper tissues. If you're not doing that, then you're really treating a piece of paper. You're treating a picture of anatomy as opposed to the reality of anatomy.
All right. Somebody asks here, do you work in any specific angle when you're trying to get into the deeper layers of fascia? Now, I typically work at 45-degree angles for the most part just to save my thumbs and my body, but is there any particular angle here?
I don't really think about it in terms of angle. Let's say that I'm going into a deeper layer. I'm using layering in order to get to the deeper layer, and then I'm using passive motion across the articulation in order to locate a line of tension. The line of tension really represents the area of fibrosis that I want to break apart. Now, the amount of compression that I use is going to be specific to the tissue depth I want to achieve. The amount of tension that I use, which is really what you're referring to with regards to the angle, will depend on the amount of tension, aberrant tension that is in the tissue.
Mm-hmm.
So if I need more of an acute angle because there's a lot of tension, then I'm going to take a more acute angle. If I can use a more shallow angle because it is not that fibrotic, then I'll use a more shallow angle. It always depends on what I'm feeling in the tissue. I'm going to give as much tension into the tissue as is being put back against me by that aberrant scar tissue. And then I'm pretty much hold that tension until it breaks apart.
James in St. Louis asks, are there any contraindications to beginning FR in the acute phases of an injury?
Of course. I mean, with every treatment modality that we have, it's obviously only going to be successful if it's applied at the right time. Now, if you have an area of, let's say that there was an injury and there is an active inflammatory process occurring, well, functional range release, the main goal of it is to break apart scar tissue or fascial restriction. If someone has an acute injury that has inflammation, the inflammatory period is going to be 3 to 5 days. At about the second to third day is when you're going to start to get aberrant deposition of scar tissue by the fibroblasts. So when would be the most appropriate time to begin functional range release? I would say when the inflammatory period starts to subside and when we can actually influence how the fibroblasts are going to lay down new tissue. So, it's like I said before, functional range release is a thought process more than a technique. So, of course, you only want to apply the actual release protocols when it is appropriate to do so from a histological or cellular perspective.
All right. Let's see if I can grab another one off of here. Will somebody ask here, will I get the same results if I do not hold the technique for at least 2 minutes?
The quick answer is no, but there's a more complicated answer that I'm hoping the video will describe. I don't hold one particular spot for 2 minutes and just kind of sit on the spot. What the FR system does is it brings the articulation into the outer ranges of motion, and I never back away from the last 10 degrees of palpated tension. So I might treat several structures within that 2-minute period, but I never completely release the tension off of that particular articulation. So in other words, the 2-minute mark is attained because I'm always kind of working within that outer range of motion. But that doesn't mean I hold one spot for 2 minutes. That would be crazy. I mean, my treatments would take 4 hours.
Right.
But now is the question, do you have to hold it for that long a period of time? I'm often asked, how long do you hold a lesion? How many passes do you do on a particular lesion? The answer is exactly the amount of time necessary for that lesion to release. I will not stop until I feel a change in the tissue. If we're to assume that we can palpate a lesion, then we have to also assume that we know when the lesion is gone. So how long am I going to hold a tissue contact? Until the lesion's gone, until whatever sparked my thought process, hey, there's something wrong here, there's fibrosis here, until that outcome measure is resolved, I'm not going to stop, if that makes sense.
Right.
I have to hold as long as I can hold.
Yeah, that makes complete sense. So a lot of our listeners on here are obviously massage therapists, and you are a doctor of chiropractic. Mm-hmm. So a lot of them are accustomed to doing, they're coming in for a timed session more than anything else, and they're also coming in with patients that have, that want full body work. So it says here, would you work specifically on an area or an issue of the body in each session, or do you work the whole body during one session?
Well, obviously, I treat a little bit different than massage therapists
Sure.
would. However, there's a lot of registered massage therapists around the world that are FR certified. The way that they kind of use it is they use the functional range release system to kind of hone in on any problematic areas. So they might do some work on, let's say, the levator scapular insertion using functional range release because they've palpated aberrant tension. Then from there, they might utilize some of their other massage techniques in order to continue on treating other areas of the body. As they're treating, if they palpate an area that feels, somewhat abnormal, they might go ahead and start to move the articulation, find some aberrant fibrosis, and then switch back into the functional range release. Really, guys, it's all about understanding what it is that you're feeling. If you feel an area of aberrant fibrosis which is decreasing relative tissue motion, then the massage therapist that is FR certified would go in to start using FR release techniques. If they felt that there was an area where there's just muscular, let's say, hypertonicity, then they might go ahead and start to use their other massage techniques that are responsible for dealing with hypertonicity. It's all about matching the application of the technique to the findings. So in one session, a massage therapist might break into some massage work, functional range release, back to massage work, progressive angular isometric loading, back to massage, back to functional range release, depending on what they're feeling under their fingers.
Right. So this kind of follows up. I think you mentioned this at the end of your presentation. Excuse me. Second part of the question is, how long does it take to see change? I think you had mentioned that after 1 or 2 visits, if you're not seeing some sort of change, you need to kind of go back and recheck your diagnosis. But one of them asked as well, how long is a typical session?
Once again, it's a very difficult question to ask because I don't really go by a time. I tend to have 20-minute visits. That's how I treat, and I accomplish as much as I can within that 20 minutes. But if I had an hour, I can probably treat for an hour. It's all depending on what I'm feeling. I think the main point here is that when I'm actually palpating tissue, I have an outcome measure that I'm looking for. I'm looking for aberrant tension. When I find that aberrant tension, that cues me into saying I need to do something here in order to correct for this aberrant tension. What am I going to do? I'm going to apply functional range release techniques. I'm going to apply progressive angular isometric loading. I'm going to do whatever I have to do in order to combat that particular finding. So how long do I work on it? As long as, let's say I have 20 minutes and there's one spot that does not want to release for 20 minutes. I might be on the same spot for 20 minutes. It all depends on the outcome measure. I need to get rid of the problem, and that's really my goal.
Yeah. See, I think, like I said, a lot of massage therapists are listening to this right now, and they're stuck in that kind of time capsule, if you will, about, I only had 10 minutes left, and I understand what you're saying. It's just they have 2 different mindsets, and they have to know how to kind of toggle back and forth between the massage and doing other types of therapies as well, I think, while they're working.
Yeah, I mean, really, the patient really won't know or doesn't care what you're doing. The patient wants to be better. They want to feel better. They want to get better. So you have to, I always think about it like I have like a utility belt, and I have several different weapons that I can pull out to combat pathologies. I'm not going to pull out a weapon just because I have 10 minutes left. I'm going to pull out the weapon that is best going to deal with the pathology that I found. Now, if you have several massage techniques, plus functional range release, plus some modalities, plus some rehabilitation exercises, the more you have on the utility belt, the more pathologies you can deal with. And that's
the old saying is, if you only have a hammer, everything looks like a nail, right?
Exactly. And I think that I don't care if you're a chiropractor, physiotherapist, massage therapist. I look at all of us as manual therapists. And what are we trying to do? We're trying to make the person function better. And that's all I care about.
Yeah. All right, I got another one here for you. This looks like a good loaded one for you. This person here was watching Tom Meyer's webinar last night. And Tom mentioned during the webinar that you should apply force across a muscle that has been injured during an eccentric load and in the same direction as the striations of a muscle when the muscle has been injured during a concentric load. Can you speak to any of that?
Absolutely. I'm very, very familiar with Tom's work, and it's good work. The only problem I have, let's just talk about fascial lines in general.
Mm-hmm.
The concept is that fascia and connective tissue spread throughout the body, making a three-dimensional body-wide communication. Every cell is connected to every other cell. So in that case, all connective tissue is connected to all other connective tissue, which is connected to all the muscles. But now we're saying that connective tissue has a particular direction, or we're saying that there are individual lines of fascia. Well, you can't have it both ways. It's either that it's completely continuous connective tissue, or it's individual lines. So I don't restrict myself to the lines of the muscle. A lot of the time the tension is felt along the lines of muscle, and that's what I'm going to treat. But if the tension is felt not along the lines of the muscle, but let's say it's going in a different direction. Let's say that the tension isn't in the muscle, but it's between a muscle and a ligament, which are completely perpendicular to one another. Am I going to simply treat along the line of the muscle because somebody wrote about these myofascial lines? No, I'm going to follow the tension. I need the two areas of fascia which are adhered to one another to move independently. So I'm not going to follow any particular line. That's not to say that I disagree with Tom Meyer's work. It's just to say that that's just not the way that I look at it. I don't think of things in terms of specific lines. I look at them in terms of what I actually feel. Now, as much as our anatomy dictates our function, so for example, there might be, let's say, the superficial posterior line, our function dictates our anatomy. So in my experience, a gymnast's fascial lines and a hockey player's fascial lines are completely different because they utilize their body in different ways. So they're going to have completely different fascial lines than anybody else would. So I think that learning about fascial lines is very good. It's a good tool. But if we restrict ourselves to the fascial lines, we're going to be missing a whole lot of problems that we can otherwise treat.
All right. One last question. Here's a little snowball for you here. Do you find, or actually it would be a hut pack, do you find using a hut packs or hydroculators prior to applying your treatment to be more effective when doing your work?
There actually is there is a good amount of research. There is actually it's a recently published review on the use of heat for flexibility training. I can't remember the author off the top of my head, but yeah, I would say that if you do have a hot pack, it would, at the very least, kind of relax the nervous system and allow you to access deeper ranges of motion, and in so doing, you would be able to really, really assess the connective tissue components that you're trying to treat. So absolutely, using heat before treatment is a good idea. Of course, going back to what we said before, you wouldn't want to utilize heat if there's an active inflammatory process going on. It all depends on what's actually happening.
All right, excellent. Well, listen, Dr. Spina, this has been fascinating. I really appreciate your time here. I'm going to send it back over to Scott, and we're going to wrap it up.
Thank you very much, sir.
Thank you very much, Drew. Those are very good questions, and thank you very much, Dr. Spina. We went over a little bit of time here, but we really want to get to some listener questions today, so greatly appreciated. Before we come to our close, Dr. Spina, I just want to ask if you had any closing thoughts.
You know what? I suppose I just want to say, like I said before, the functional range release technique is not just a technique; it's really a thought process. And I think that's really how I want to differentiate it and how it is differentiated from a lot of the other techniques out there. It's a matter of actually paying attention to what it is we're actually feeling and then trying to affect change in whatever it is that we're feeling. So that's really the moral of the story, if there was one.
Wonderful. Well, Dr. Andreo Spina, thanks so much for your presentation.
Dr. Andreo Spina, FunctionalAnatomySeminars.com. I'm the creator of the Functional Range Release Soft Tissue Management System.
I hope that you enjoyed the PowerPoint component of the presentation, and now we're going to go into the video component. First off, I want to thank the World Massage Conference for putting on such a wonderful group of presenters and such a wonderful event. And I'd also like to thank Dr. John Sarasiotis for doing part one of this presentation, really introducing the applied science of or behind the functional range release soft tissue management system. With my presentation, I wanted to give you more of a clinical basis as to utilization of the technique. And now with the video component, I'm going to try to further explain how FR release practitioners manage patients, as well as demonstrate some of the actual treatment techniques. So what we're going to start off with is I'm going to run through a mock patient using the patient flow chart that you saw at the end of the PowerPoint. This will take us right through an example of how we would utilize a clinical history, use our functional anatomic palpation system skills to localize the lesion and then assess the lesion, and then we'll take you right through the application of the FR release protocols, as well as the rehabilitative components that we might prescribe for this particular mock patient. Following that, I'm going to show you some examples, actual real case examples from my private practice, demonstrating how I utilize some of the more important components of the functional range release system. So there's going to be an example of me utilizing layering system, utilizing progressive angular isometric loading, demonstrating the flow of treatment with functional range release, as well as some other examples.
What I want to do right now is go through what we refer to as the patient flow chart, which is the way that we take in and process our clients right from taking a clinical history into the release of the soft tissues, and then how we progress them into rehabilitation and then into conditioning protocols. So the example we're going to use here would be someone coming in with, let's call it a non-specific low back pain. Obviously, the first thing that we do when somebody comes in for assessment is to take the clinical history about the condition to try to narrow down our differential diagnoses. Once the differential diagnoses have been narrowed down, we'll then go into our assessment techniques. If we go by the literature regarding some of the assessment techniques for manual therapists, we see that there's a lot of downfall to the utilization of orthopedic testing. Most orthopedic tests are very non-specific. So what we want to do is we want to utilize our palpation skills. So the first system that we utilize in the functional range release management system is that of functional anatomic palpation systems. This is a system designed to teach the practitioner how to very quickly, efficiently, and effectively localize soft tissue pathologies or problems with this soft tissue that are leading to biomechanical dysfunction. So in this particular patient, let's assume that we've gone through our clinical history, I've assessed them with the palpation techniques, and we have found that the location of the primary lesion is in the dorsal sacral ligament. So if we look at the anatomy of the dorsal sacral ligament, we know that the dorsal sacral ligament has actually two components. There's the long dorsal sacral ligament, which spans across the sacroiliac joint itself, as well as the short dorsal sacral ligament, which is more of a horizontal orientation going from the lateral portions of the PSIS inwards towards the sacrum. Once we have localized the specific lesion, our next task is to imply or impart the tissue tension technique. The tissue tension technique is a way for us to palpate an area of tissue that's pathologic in order to discover or to determine where the lines of fascial tension have developed. Lines of fascial tension, of course, are representing adhesion or fibrotic tissue. The first level of palpation in this tissue that we're going to do is to palpate the fascia superficialis on top of the fascia profunda. We refer to this as interlayer palpation. Right on top of the PSIS, in people who have chronic sacroiliac joint problems or chronic dorsal sacral ligament problems, one of the first findings that we'll discover is a loss in the movement or loss in the relative movement between the fascia superficialis on top of the fascia profunda, such that when we challenge the fascia superficialis on profunda, we have a loss in directional movement in a particular area. So in the case of this patient with a right-sided dorsal sacral ligament pathology, we see that going superiorly there's quite a bit of relative movement, medially there's quite a bit of bit of relative movement. Inferiorly, we have lots of movement. And then if we go laterally along the iliac crest, we find a restriction in the amount of movement between the fascia superficialis and the underlying profunda. So the first level of treatment, or for functional range release, will be to remove any scar tissue or fibrosis located between these two levels, which in this case will involve us creating a wedge in the skin, which is actually wedging the fascia superficialis over the profunda, and then holding that tissue in the direction of the movement block. We hold this tissue until we feel a release in that fascia, which allows that relative motion to occur in the tissue. So we then go to intra-layer assessment. In order to assess these structures, we use the tissue tension technique in ways that actually cause movement in the tissue assessed. So in this particular scenario, what I'm doing here is by putting the leg into an internal rotated position, I'm gapping the sacroiliac joint and I'm looking for movement blocks in the sacroiliac tissue, in this case on the short dorsal sacral ligament. If I get the patient to lie on their left side, I will also assess the tissue along the long dorsal sacral ligament by bringing the hip into flexion. In this position here, I'm simply looking for lines of tension which would be abnormal in the actual pathologic tissue. So right now we're really honing in on the specific diagnosis, which would be the strain of the dorsal sacral ligament. Once I find a block in the tissue, our next job is to apply functional range release in such a way to release that movement block. So in the case of a dorsal sacral ligament, I can release the short dorsal sacral ligament by taking tension onto it, by compressing the tissue and taking tension within, and then moving the leg into the outer ranges of motion. So in this case, I'm gapping the sacroiliac joint in order to release the fascial tension within that short dorsal sacral ligament. With our first level of treatment, we also apply what we call PALS, or Progressive Angular Isometric Loading Level 1. In Level 1 PALS, we'll have the patient, once I've palpated the end range of their motion and I've released the tissue tension for a particular motion, I'll have the person hold strong as I'll apply a pressure against the person's leg. Then I'll have the patient release. As you see, when they release, the body will open up approximately 10 to 15 degrees more motion, at which point I can then reapply my soft tissue release techniques into the new range of motion. Thereby, using PALS techniques, I'm accessing newer ranges of motion so I can further release the fascial fibrosis. So I'll do this for the short dorsal sacral ligament, as well as to go in for treatment into the long dorsal sacral ligament. So once again, I'm taking tension into the long dorsal sacral ligament, and I'm utilizing the motion of the hip into flexion in order to release tension on that dorsal sacral ligament. For the functional range release technique, we emphasize the last 10 degrees of motion. These are the degrees of motion which will actually cause a fascial stretch and will actually allow us to impart relative tissue motion between one layer on another. After we've done the fascial range release with the level 1 PALS, let's say the patient comes in for another visit 2 to 3 days later. If the patient has improved, we'll then move on to our level 2 of treatment. If the patient has not improved, we'll go back up into retaking the clinical history, redoing our palpation techniques, and then retreating the area of the problem. Let's assume this patient comes back and they're feeling much better. It's now our job to try to discover what other tissues in this area could have been contributing to the biomechanical movement block which would have led to this primary problem of the dorsal sacral ligament sprain. So for example, some tissues which will cause a movement block in leg flexion or hip flexion might be the sacrotuberous ligament, the hamstring muscle group, or coming up into the thoracolumbar fascia. So as the patient gets better, our treatment scope becomes wider. So now we're going to assess more and more tissue using our tissue tension technique. So now I'll try to contact various tissues that might be contributing to the block, which we refer to as functional range synergists. And I'll utilize patient motion in order to feel areas of restriction in the patient's tissue. So for this patient, I feel fascial restriction coming down into the hamstring group. Because I'm feeling this restriction, I will actually go and I will do my functional range release protocols into all of the functional range synergists that might be contributing to the movement block. So for the proximal hamstring tendon, if I get you to relax, I'll simply compress and take tension into that hamstring and then I will move the hamstring into the last 10 degrees of motion, and I'm going to release tension in any line that I feel it come into my finger. Once again, if I feel that the person, I've got to the end range of palpated tension and I need to access more range of motion to further release that tension, I'll have the patient contract against me, hold for a few seconds, now relax, and then I will further delve into the person's tissue tension by expanding their range of motion. The better the patient gets, the more force they're going to be allowed to push on me without pain. This is where we change from Pales Level 1 into Pales Level 2. Pales Level 2 is the beginning of trying to strengthen the newly acquired range. So now that we're getting more range of motion, the movement block has been decreased, the person has more range, now we want to try to teach the nervous system how to actually utilize that range. So instead of just getting him to contract and relax very quickly, now we'll get the person to contract against me, ramping up the contraction as hard as they possibly can, and we will start to hold for longer periods of time. Now relax. As they relax, I'll increase the range, and then I'll go and try to find new lines of tension which I can release. Fast forward a few more treatment visits. The person comes in, they're relatively pain-free. On palpation, I no longer feel any movement blocks which I originally felt that were leading to the patient's complaint. Now it's the job of the practitioner to go into Pales Level 3. Pales Level 3 is also known as functional range conditioning. For functional range conditioning, we're going to assign exercises to the patient whereby they will try to extend or try to strengthen the extended range of motion which has been provided for them through our treatments. So in the case of this patient, if you just sit up for me, stand up for me, we said that he highly had a movement block into hip flexion. So with our treatment, we've extended the amount of hip flexion the person is able to achieve. So now we want to prescribe exercises in order to try to strengthen that range of motion. So for example, if I get you to turn around this way, we'll go with a hip flexion block stretch. So from this position here, with the knee bent, we're going to teach the person to increase their lumbar lordosis by sticking the buttock out, coming chest forward, and holding until they feel a pull. Once they've held that stretch for a prolonged period of time, be it 2 minutes or 3 minutes, we'll teach the person to ramp up a contraction against the table, hold the contraction for as long as they possibly can, which is with as much force as possible, and when they relax, let out a deep breath and extend further into the stretch. So what we're doing with functional range conditioning is we're increasing the person's functional range of motion by actually teaching the tissue how to contract and how to function in those extended ranges of motion. When people increase flexibility but they don't increase their strength within those flexible ranges, the body will never incorporate those ranges of motion into actual functional capabilities or functional tasks. But for this particular patient, if he can get strong over an entire range, he'll be able to utilize the entire range of motion. This is how we discharge the patient now. We'll give him stretches, we'll give him exercises which will help to increase his functional ranges, and then we'll discharge them. If they have pain again, of course, we'll see them again, or we'll bring them back for what we call performance care. In performance care, we'll take the person and we'll just work on improving ranges of motion and improving strength within the newly acquired ranges.
Okay, so we have a competitive jiu-jitsu player, heavyweight division, with a partial pectoralis tear. We're well into the healing process, and we've been working with Pales in order to increase his outer ranges of motion. But there are still some fascial restrictions. So I'm just going to go through and I'm going to find those lines of tension and begin to release. So in this case here, bring the camera here, I'm checking multiple ranges of motion and I'm feeling for a line of tension. Okay? And what I feel is the line of tension is coming right through the underside of the pectoralis major, taking my contact, compressing into the tissue, tensioning the tissue, and then I'm going to start working that range of motion. This is about the second or third treatment with this particular patient, so he's been working on some Pales Level 2 exercises to try to strengthen the outer range of motion as he improves. Okay, so in this range here, I'm finding a little bit of restriction, but I'm not feeling the fascial fibrosis anymore. So I'm going to utilize a Pales to just increase his range and get you to hold strong. Okay. Applying the contraction in the exact line of tension that I want to assess. And now I'm going to get him to relax. So as he relaxes here, I'm getting a little bit more range. So I'm going to reassess the area. Now I'm feeling tension. The next line of tension is between his clavicular head. I don't know if you can get this. It's between his clavicular head here and his sternocostal head here. So right in his epimysial groove. So I'm going to tension into there, and I'm going to start to work this range of motion here.
In this short clip, we have a patient who had caught their hand in a conveyor belt. As you can see, it left some significant superficial scarring, which is hindering her ability to move as the fascia superficialis is adhered to the underlying profunda. So what you just saw me doing was some interlayer assessment to find a line of tension, and now I am simply creating that skin wedge and creating relative motion between the fascia superficialis on the profunda and holding that tissue until I can get a significant fascial release. Following this, you will see me reassess the motion, and if you see me moving the finger, in that case I'm sliding the tissue underneath my contact. That would be a treatment of the profunda fascia or intra-layer treatment using the FR release technique.
Okay, so we have a case here of a distal radial fracture. The patient's cast was just removed. So in checking range of motion, we can see that we have quite a bit of restricted range of motion. So the idea now is that, is this range of motion restriction due to capsular fibrosis, or is it due to increased sensitivity of the stretch reflex? So what we're going to do in this situation is we're going to utilize Pales contractions in order to both increase the flexibility / mobility of the wrist, as well as to begin to develop the strength in progressive angles into extension as well as into flexion. Okay? This is going to simultaneously deal with the neurological tightness component, allowing us to get further range of motion to access the fascial fibrosis. So this is a range of motion now. Okay, so I'm just going to ask that you very slowly develop tension and extend the wrist into my finger and hold. So the patient is asked to do as much contraction as they can to their tolerance. As we treat this particular patient, her tolerance will get higher and higher. So eventually we'll be at full grade contractions during the Pales maneuver. So we'll progress from a Pales 1 to a Pales 2, and then eventually to Pales 3 exercises. And relax slowly. So when she relaxes, I'm taking up the newly acquired range. I'm taking up that slack. And now we're holding in the newly acquired range to allow for fascial modification. And then after I've held this position for a substantial amount of time, we're going to repeat the process in order now to strengthen in the next 10 degrees of motion. This would be repeated in a case like this, either post-surgical or in this case where we have a cast that's been removed, until I've eliminated all of the neurological component of the tension, at which time, when we're at when the end range is being restricted by the actual fascial components, then I can utilize the FR release in order to break down the fascial fibrosis that's occurred. You can see how this differs from various other stretch techniques in that the goal here is not only to improve on the motion, but also to strengthen the newly acquired range. You can see how we went from a neutral, and now we have approximately 20 degrees. What we're going to go over today is a really good example as to why the functional anatomic palpation systems courses are so useful for practitioners, even those who feel that their anatomy is very strong and their palpatory skills are strong. If you've been following my blog or our seminars, you know that the FAP seminars teach very specific manual assessment by way of palpation, and many of the practitioners that come to the seminars are often amazed at how the 3D structure and how palpating live anatomy differs from the way they were taught in school, which is usually a two-dimensional kind of situation. One of the most common problems that we see, one of the most common areas, is with the levator scapula muscle. The levator scapula muscle is a really, really obviously common area that people believe that they're treating. I think that people write that it's the second most common trigger point, et cetera, et cetera. Now, where people mostly find problems with the levator scapula is they point to this spot right in here, okay? And from this position, they'll take contacts going in this position. They'll start to treat the levator scapula in this fashion here. Now, just to review the anatomy, the levator scapula is coming from finger-like projections on the lateral side of the neck, coming inferiorly to attach onto the superior angle of the scapula. Now, just so we base ourselves in our anatomy, this is the spot where people usually say that the levator scapula is problematic. If we palpate lateral from this spot, we realize that we're actually in line with the spine of the scapula. So being in line with the spine of the scapula, that means the insertion point of the levator scapula is approximately 2 centimeters superior from this spot. So you can see from the spine of the scapula, in order to get to the superior angle of the scapula would be in this region here, which can be very easily palpated by putting the person's arm behind their back, which will tilt the scapula forward, and you can feel a very sharp structure in this position here, which represents the superior angle of the scapula. So what this tells us, even though a lot of the anatomy textbooks show the levator scapula from a P to A diagram, the levator scapula is more accurately known, or should be more accurately thought of, as a lateral cervical muscle, not a posterior cervical muscle. So for the actual palpation of this structure, if we put the person's arm behind their back, the one muscle that will be on top of the levator scapula is obviously the upper trapezius. Many people would ask me, how do you palpate through the upper trapezius in order to get to the levator? Well, number one, the first important concept to understand is that the upper trapezius is such a thin muscle that it is almost inconsequential with regards to human movement and biomechanics. I'm going to show you the actual fibers. When somebody's just sitting like this, it looks like the contour of their neck and shoulders are made by these trapezius. However, when you actually look at the upper trapezius muscles, you can see exactly how thin the upper trapezius muscle really is. Can you get that in the camera? The upper trapezius muscle are very, very thin fibers. Most of them are not even muscular fibers. A lot of these fibers are simply fascial or connective tissue. And if you read the article by Bogduct, if you search Bogduct and upper trapezius, he describes in great detail how the upper trapezius are not even a very important muscle in terms of movement of the shoulder and cervical spine. Okay? So if we go from the upper trapezius, anteriorly from the upper trapezius, the next muscle that we will find will be the levator scapula. So if I take his arm and I tilt his scapula forward, the next muscle that we can flip over in this position here is going to be the levator scapula. We can follow the finger-like projections of the levator scapula all the way superiorly into the lateral cervical spine. So we can actually strum the individual insertions of the levator scapula superiorly. If you wanted to palpate the insertion point of the levator scapula, you would have to follow this structure down inferiorly until you hit upon the bone of the superior angle of the scapula, which would be located in this region here. Once again, you see that where most people are palpating or think they're palpating the levator is approximately 1.5 to 2 inches off of the actual insertion point of the levator scapula. Hence, in the functional range release treatment system, our access to that levator muscle actually occurs anterior to the very paper-thin upper trapezius muscle. Okay, with this patient, we are 2 months post-surgery for a ruptured patellar tendon. So the first thing that we did was to reestablish a range of motion, which was done very, very quickly by using PALS, progressive angular isometric loading. What we found post-surgically is that the number one restrictor was the neurological tightness imparted by the increased neural drive going to the muscles. So we couldn't release any of the capsular restriction until we dealt with the increased neural drive. And one of the ways to deal with that is to utilize the PALS system. So as you can see, 2 months post, we have almost a full range of motion, which is not a common finding for someone who's had a complete tear. So if you come in here now we're dealing with the FR release techniques. So for this particular patient, he's saying that he's having a little bit of tightness underneath the kneecap. So what we're going to do is we're going to check, first, as we always do, we're going to check the interlayer movement. So we're going to look at the scar and find any restrictions in scar mobility. So I find that going superiorly, we have a lot of motion. Laterally, there is some block going this way. And inferiorly, I have quite a bit of tension. So first thing we're going to do is we're going to begin some interlayer treatment on the inferior scar, the inferior portion of the scar. Okay, so now we've done some work using interlayer release, and we see that we have very good superior mobility, our lateral mobility has improved, and our inferior mobility is also highly improved. So now we've dealt with interlayer scar release. Now I'm going to go and see if we can find some intra-layer restrictions by actually utilizing movement and assessing using our tissue tension technique. So I'm finding a line of restriction, capsular restriction along this area going in this direction, which is actually exactly what that patient has explained. So we're going to take the person to the end range. I'm going to take my contact as usual, and I'm going to start to work that last 10 degrees of palpable motion. If I ever needed to improve or increase my motion, we would then utilize a PALS technique. In the case of this patient, because he is, I would say, intermediate level with regards to his rehabilitation, we would be using the PALS level 2. So I would have him, if I wanted to improve flexion, I would have him hold strong, and then I would push and hold against his leg for as long as he can sustain the contraction for, and then when he relaxes, I will take up the next 10 to 15 degrees of available motion, and then I will continue to work along that line. With treatment flow, as we call it, even though I might start in this area, as I reassess, I'll go and assess other functional range synergies. So a treatment that starts here may very well bring me all the way up into the pelvic joint or all the way down into the foot, depending on the line of fascial tension that I'm following. Now, in some other techniques, what people do is they take contact onto that muscle, and then they go ahead and try to treat through an entire range of motion, all the way up to knee extension. Obviously, that's not going to be possible because you have an overlying gastroc. So when you're palpating and touching the popliteus, as we show in the functional anatomic palpation systems seminars, when you have that contact, you cannot utilize knee extension to treat because the superficial gastrocnemius will pop you off. This is also a good example of why FAP is so important in proper palpation technique. The popliteus muscle is not located in the popliteal fossa where most people think it is. The popliteus muscle is actually in line with the fibular neck. So in FAP we use a reference structure called the soleal line, and from the soleal line we can drop superiorly, we can layer through the gastrocnemius, which allows us to sink right down onto the popliteus muscle quite easily, and then utilizing rotational movements we are able to treat that popliteus and not become layered off because we're using knee extension. Again, this is just one example of how important the layering technique is for not only treatment purposes but also for diagnostic purposes.